Look at the structure of this torn bread. For most people, this matrix of wheat proteins provides harmless, everyday nourishment. But for about 1 in 100 people, this exact structure acts as a slow, undetected poison. Celiac disease is a permanent, immune-mediated multisystemic disorder. It involves a systemic physiological response that reaches far beyond the localized sensitivities of a typical food allergy. When gluten molecules enter the small intestine, the immune system misidentifies these proteins as hostile invaders and mounts an aggressive attack. Zooming in, you can see the collateral damage. The healthy, finger-like villi, which normally absorb nutrients, are completely flattened and destroyed in the crossfire. Because this battle happens deep inside the gut, it blocks the body's ability to absorb essential vitamins and minerals. The result is a cascade of vague, overlapping symptoms like severe fatigue, anemia, or joint pain that often mask the true root cause. When faced with chronic digestive pain or exhaustion, a suffering patient's first instinct is usually to try and fix it themselves. They read about the effects of gluten, cut it out of their diet entirely, and wait to feel better. This logical reaction creates a clinical conflict. By removing the trigger before seeking medical help, patients inadvertently scrub away the very markers and tissue damage doctors rely on for a definitive diagnosis. Without gluten passing through the system, the gut begins to heal. The immune system stands down and the specific antibodies fade from the blood, effectively hiding the disease process from standard medical tests. To permanently stop the disease, the patient must first definitively prove its existence. This requires them to continue feeding the very process that is damaging their body until the diagnostic window is complete. Because the testing process is so easily derailed, gastroenterological authorities have established strict clinical protocols. Here, we are looking at the official guidelines from the American College of Gastroenterology, which outline exactly how to navigate this diagnostic maze. The first requirement is what doctors call the gluten challenge. If a patient has already stopped eating wheat, they must reintroduce a minimum of 3 grams of gluten into their daily diet for a full 6 weeks before taking any tests. This flowchart maps out the initial screening process during that dietary challenge. The primary tool is a blood test looking for elevated levels of the IgA anti-TTG antibody, the specific marker the body produces when attacking gluten. But looking at the bottom pathway here, you'll see a critical failsafe. Doctors must measure the patient's total IgA levels concurrently. If a patient has a natural deficiency in IgA, the standard test will show a false negative, causing the doctor to miss the disease entirely. There is one genetic loophole that can spare patients from the gluten challenge. Doctors can test for the HLA-DQ2 or DQ8 genetic markers. If those specific genes are completely absent, celiac disease is biologically ruled out right then and there. While positive genetics and elevated antibodies provide an incredibly accurate map of the immune response, blood tests alone do not yet offer absolute proof of the disease. To lock in the diagnosis, doctors go inside and look at the battlefield directly. This requires an endoscopy, where a small camera is guided straight down through the stomach and into the upper digestive tract. The goal is to perform a duodenal biopsy. By extracting tiny physical tissue samples from the lining of the small intestine, doctors capture undeniable, microscopic evidence of the physical damage. Pathologists examine this tissue in the lab for very specific markers. They look for visual confirmation of villus atrophy, the flattened absorption structures we saw earlier, alongside crypt hyperplasia, which is an abnormal thickening of the intestinal glands. Exceptionally high antibody levels, specifically 10 times the upper limit of normal, can occasionally substitute for a biopsy, though physically sampling the tissue remains the preferred method for most adults. Combining the invisible antibody map found in the blood with the physical, localized evidence of tissue damage is the only way to officially secure the diagnosis. Once confirmed, the medical intervention is remarkably stark. There are no daily pills, no targeted biological therapies, and no surgeries. The only treatment is a strict, lifelong commitment to a completely gluten-free diet. This diet must be absolute. Even microscopic cross-contamination from a shared cutting board or a restaurant kitchen is enough to reignite the immune war inside the gut. This timeline illustrates the biological reward for that intense discipline. Over several months of strict dietary adherence, the flattened intestinal villi gradually regenerate back to their full height, restoring the body's ability to absorb nutrients. This dietary treatment represents a permanent, uncompromising treaty. Constant vigilance keeps the immune system dormant, maintaining internal peace and preventing further systemic damage. Because that peace is so fragile, long-term medical monitoring is essential. A patient might stop feeling sick, but the simple absence of outward symptoms does not guarantee that internal intestinal healing is complete. Official medical guidelines require patients to have their antibody levels retested every 3 to 6 months during the first year, and then once annually for the rest of their lives. Doctors specifically monitor for non-responsive celiac disease. If symptoms and antibody levels persist despite a strict diet, the cause is almost always found in hidden, unintentional gluten exposure within the patient's daily environment. Once those blind spots are eliminated, the prognosis is excellent. A precise diagnosis combined with absolute discipline successfully restores the body to full, lasting health. Mastering celiac disease requires navigating a counterintuitive diagnostic process and enduring symptoms long enough to secure the evidence. Only then can a patient take total control over the food that sustains them.